Season 4, Donna. Season 4.
know.
I know. Welcome, everybody, to another episode of the Med List. We're so glad to have you guys here. My name is Dr. Kevin Walker, and this is Dr. Donna Bartlett, and we're excited to be able to talk to you about another thing happening in medicine that I feel like just needs a little bit more clarity. We need to humanize it a little bit and hopefully make it a little more simple for us to be able to make choices. But how have you been? I've missed you. It's been way too long.
I know. It's been a nice little break before season 4 started, but everything is great. And a little R&R, and you know how you take those breaks and you just keep going and doing and finding new things to do. So I don't know how much R&R I've had, but it's been a good break.
Very active, successful break. Well, that's so good. Yeah, same. It's nice to get some just additional kind of family time. Nice to kind of think about the ways that we're going to approach kind of every season. I love when you and I take a break, that just the guests we invite on, there's almost some theming kind of related to the guests. And I think the quality of guests has always been incredible. And I'm really excited about this one that we're going to bring on today. I think with Cynthia, the whole pain cycle, it is interesting, Donna, the number of times I'm guessing you and I in our careers have encountered individuals that have pain related problems that they feel a sense of hopelessness around, right? It just, I can't get enough treatment for it. This doesn't work any longer. I feel like there's other problems related to the pain. And a lot of times the treatment piece, of us having an acute injury, or we have a pain that's continually to progress, a cancer related pain, a diabetic neuropathy that a lot of folks are kind of used to. Those ones, there are treatments that are available. There are a lot of episodes I'm sure Donna and I will have going forward really related to those. But this one's a little bit unique, Donna, the way we're going to be able to talk to Cynthia about this particular type of pain. Do you want to describe it a little bit for the audience to have a better understanding before we go live?
Yeah, so I do think, just to add a little bit to what you just said too, Kevin, is not only are people on pain relievers, but there's also a whole prescribing cascade that goes on with pain relievers too. So, and as you know, we love this whole med list idea of let's only take what we need. So if we can reduce pain and do it in a well-mannered way, maybe we can stop some prescribing cascades too. But there's so many different types of pain, and we have to identify it, and we have to understand what exactly is being treated. So the neuroplastic pains, nociceptive pain, retrain a little bit about just saying, okay, do you have pain still? And asking that question of patients and caregivers, does this person still have pain, or are we continuing treatment and there is no pain that's being complained about? So there's so much around this with true pain. Not that I want to say that there's a fake pain, but there's some like more psychological neuroplastic type of pain versus an actual injury to someone's organ or bone or tissue that is causing pain and needs to be healing. So, so much to learn today.
I think that's super helpful. And I know one pain that we're really thankful that we have some colleagues and our partners at Remedy Chain to take care of is the pain of not being able to afford or find medications, right, for individuals. And really thankful for them and the work that they're doing, and want to show you a little bit of info about them. So if you are in need of a medication that you can't either afford or a family member can't, or if you have medications to donate, here you go.
At Remedy Chain, we know throwing away perfectly good medicine feels doubly wasteful. It's bad for the environment, and it could have been used to help a fellow human in need. So we found a remedy. Now you can donate your unused meds. Our pharmacists inspect and certify every donation so it can be safely and legally redistributed to vulnerable patients. Visit donatemymeds.org and click the Donate Meds button. Unopened, unexpired medication in original packaging is eligible for donation. Open bottles, controlled substances, and temperature-controlled meds are not eligible for donation. Once confirmed, we'll send a donation form to sign and prepaid shipping instructions. And we'll let you know once we've matched your donation with a patient in need. Together, we complete the chain. Remedy Chain. Visit donatemymeds.org today.
Awesome. And without further ado, let me bring Cynthia to the stage.
Absolutely. Hi. So welcome, Cynthia. And today we have with us Cynthia Austin. And I just want to share a little bit about you and your story. At her lowest point, Cynthia Austin was disabled by chronic pain, walking with a cane, and unable to work for over 15 years. When doctor visits brought no answers, she turned to pain research and everything changed. Learning how the brain and nervous system create pain helped her find lasting relief and reclaim life. Now a nationally board certified health and wellness coach, Cynthia founded My Pain Coach LLC to help others do what she once thought was impossible, change the pain experience. So that's so powerful, Cynthia. And I'm just so thankful that you are with us today to share your story and your expertise so that we can help providers and patients and caregivers really navigate this area of pain.
Yes, thank you. I'm really excited to be here and have this conversation. It's so important. People need to understand that neuroplastic pain is something that can be changed. There's a way around it. Yeah, so that's some of my story. But before, like you said, before I became a pain coach, I spent almost 50 years living with pain. And
Wow.
so you're right. I read the research and it slowly started making sense to my own story. And little by little, I started changing things. It took a long time, but I started changing things. So I'm really excited to talk about this, to try and bring some hope to people, and for clinicians also to understand how to help these people when they just have nothing left and they say you must learn to live with it. That's almost like a death sentence. You must learn to live with this pain. So there are answers.
Yeah. Could you share a little bit more of your story? And, thinking that someone's living with pain for 50 years is tremendous statement all in itself to just even try to comprehend that. But then you said, you started researching, and what was, if you could tell us a little bit more about your pain and the different types of pain, but then what was your aha moment that maybe there are answers out there, even though I haven't been getting any answers?
Yeah, so I think my journey to become a pain coach started when I was 7 years old, because I was diagnosed at 7 with migraines. And then over the years, lots of little different symptoms came in, moved around, morphed, and lots of them were medically unexplained. They just kept popping up. By my 40s, I was completely debilitated, almost completely bedridden, couldn't drive. I used a cane, 100 pounds overweight. Like you said, couldn't work. And I was on a plethora of medications. You were talking about pharmacy cascade. I was living in that world. I'm very happy I'm very thankful that I'm alive because some of the combinations they had. And so all this was happening and my mental health was deteriorating. But the only thing the doctors were concerned about, the only thing they were looking at were the physical symptoms. So when the test started not matching the pain, the level, and because my pain was going up, it was escalating. They actually started blaming me, saying that I wasn't trying hard enough. I needed to learn to live with it. I needed to exercise more. Just think positive. Go home, do yoga, take a mindfulness class, and all of this was supposed to fix me. It was supposed to make it better. But this is what doctors were saying to me, and then you go out, you get pushed out the door, and that's it. So there's no one to help you. So like I said, my mental health was deteriorating. I was desperate for answers, and that's how I got into the research, because once my healthcare team no longer believed me, I had to look outside of the people I was working with. And so I started reading research about chronic pain, trying to understand what was happening in my body.
Yeah.
And the more I read, it made sense, because the first research that I read was about social relations, the engagement between couples. And it made total sense that the fear was playing into my pain. It was creating this pain cycle. I think we'll talk about that even more. But that's how my pain started. It was through emotional stressors, mental stressors.
So describe that a little bit further, I think, just to give kind of the audience a good idea of like what was a day like for you at that time? You wake up in the morning, you get out of bed. What are the pain that you're feeling? How did it cycle? What are the things you're trying to do at that stage to try to deal with it?
Wow. So when I would, yeah, when I would when I was living in the full pain experience, I would wake up and did not want to be awake, but I had to get up. I had to go do certain things in the morning to help my husband at that time. It And then as soon as you got done with what you were doing, like making lunch or breakfast, then you had to go sit down and sit on the heating pad, or go lay down. My life was literally back and forth between the bed or the chair, the bed or the chair. My 80-year-old mother drove me to my doctor's appointments because I couldn't drive. So it was just day in and day out suffering. And that's why I do the work that I do, is because people are suffering needlessly. There are answers. So yeah, day in and day out, it was misery. It was very hard to just take care of my daily needs. I think it's 20 million Americans have the type of pain that interferes with their daily needs, like showering, brushing your teeth, having the energy just to get up and brush your teeth, just to get up and go to the bathroom because you know the pain's going to kick in as you take that third or fourth step. So it was just pure suffering. I didn't know what to do other than to keep reading the research, and then slowly the picture started coming and becoming clearer and clearer. Then I went back to school. That's where I found all the real research and really started really understanding how to apply this stuff. But that came much later.
Wow. It with the daily kind of occurrence of getting up and feeling like I wish I was back in bed, and then every activity kind of leading to exhaustion, right? And just the exhaustion of being in pain and wanting to be in a still place just to be able to deal with it in general. The pieces that kind of come together in my mind for next kind of social connects are: one, you felt somewhat abandoned, right, by your provider team, right? That they were at a point that either one, they were frustrated, or they didn't have any more answers and they didn't feel like they could help. And therefore they thought, I don't know what to do next, and this is the only thing I can do, right? When it came to family and your internal supports, you just mentioned your mom taking you back and forth to appointments. What was the structure like in the household and in the home, supporting you and or helping along the way, or not helping along the way, when it came to kind of realizing and recognizing this? Why I ask it, Cynthia, is because this is so many families are impacted by it, like you just mentioned. And sometimes they're not the individuals in pain. They're in the individuals that are trying to recognize or connect with their family member that's in pain. So can you walk us through that piece?
Yes, the caregiver is an unsung hero. I'll just state it like that, because it is very difficult for caregivers. So the support, I felt very abandoned by my medical team. So that landed into my mental distress, thinking that they didn't believe me, they weren't going to help me, and I was alone. The situation I was in at home, I was in a failing second marriage. The support was not what I needed at that time. And so I ultimately left that relationship. That was actually part of changing my pain experience, was changing everything about my life. I literally had to change everything about my life to change my pain experience, because of the mental, emotional, the traumas that had happened in my life. There was multiple traumas from 7 years old, at 16 years old, and then later in my life with 2 marriages. So that's what was playing into my pain experience. So then the unhealthy marriage was actually playing into it too. Family, there wasn't a lot of help there, because everybody had their own lives, and they had their own pain, literally, because there was a family. Everybody had pain in this family, so they had their own lives, their own worlds, their own traumas, and I was alone. And every day it got more and more and more alone. Yeah, I didn't have a lot of help, to be really honest, at that time.
That's so helpful to know that piece, to know that what the surrounding circumstances are like for individuals. And after working a little bit further into it, is that the scenario you just painted there of how you were feeling personally, what the medical team was kind of dealing with or trying to work with it when it came to next steps for you, and then the family support and environment common amongst many of your clients that you've worked with when it comes to those scenarios, all matching yours fairly closely, or has been fairly diverse when it comes to those three aspects?
It's very close. And that's the thing about all of the pain experiences, the same nuance, very different nuances as far as the types, but
Yeah.
what the people come to me and they're telling me are the same experience. That's when I started finding out there were so many other people that were experiencing what I was experiencing. That's when I got angry, to be really honest. I thought this was crazy that people are being treated like this and they're becoming suicidal. I spent, I don't know, maybe thousand, hundreds of people before I became a pain coach. I just talked to people trying to help them because they were saying that they were going to kill themselves because they couldn't live with the pain.
Oh my
And so that's how I started, was just talking to these people and trying to learn how to help them. Then I became a professional pain coach. So now I know how, but these are the same stories. They're all bringing these same stories. Pain management gave up on me. They told me just to learn to live with it. I had a girl that was 17 or 18. She was a professional dancer. And they told her, you just have to learn to live with it and give up dancing. She didn't have to give up dancing. She had to modify, but she didn't have to give up dancing. So, yeah. I'm sorry if I got off track. Sorry.
You didn't. That's just perfect.
Yeah. I can imagine that we talk a lot about isolation too, and how that is such a factor in people's health and health span. I can imagine pain is very isolating, just like someone who might lose their vision or lose hearing, that, you kind of become your own entity. And if you're in pain and not getting out, and I can just imagine it can be isolating. And like you're saying, people don't know what to do for you or with you, or know how, like you're saying, the caregivers are these unsung heroes. And then if they feel that they can't help you either, then I can just imagine the isolation that surrounds that. So I'm sure that plays a factor too.
Yes. Not being able to get out, then you start feeling that you don't have, well, when you start not being able to get out, it comes from physically not being able to trust your body. So the self-trust in your body goes away. And that's more, you start becoming your own bully. I can't believe my back is hurting again, and now I can't go to this thing. The other side of that is that people with chronic pain tend to cancel a lot, and that ends up losing friendships, family members, support. So people, because they have to cancel because they can't get through. Or the other side of that coin is they push through. And to meet the needs of everybody else in the group or whoever it is. And then that is its own push into the neuroplastic pain, and keep it ignited and keeping the nervous system activated into that fight or flight, and which keeps the pain going. So pushing through and then faking it and pushing through. But so then you start thinking people are thinking badly of you. So all of this balls up together and becomes an experience with the pain. The brain makes meaning of all of this. And that's why the neurons start firing together and wiring together, is because the emotions and the pain wire together and the brain makes meaning of it. And if the meaning is I'm worthless because I can't even make it to dinner, or I have to carry my heating pad, or I have to carry X, Y, and Z because I can't just go or be spontaneous.
Yeah.
So it's very isolating. You start thinking I'm not good enough. And then the self-bullying starts kicking in.
Sure.
Wow.
Could you tell us a little bit more about the different types of pain, like you're talking about? So this neuroplastic pain, if you could, and I know that's more or less what we are geared towards today, but then also the different methods too. And I might be like jumping and asking like too big of questions, but this whole neuroplastic pain, and then like this neuro pain kind of therapy that you are engaged in and that has helped you and that you're able to help others?
Yes. So the types of pain in a very, very nutshell, nociceptive is tissue, the injury, inflammation. Those are the things like cuts, burns, and sprains. So that's that type of pain. We're not talking about that type of pain. Although I will say there is an emotional component to that type of pain, to injuries, that we can apply what I do, but it's not the same thing. Neuropathic, not the same thing. Nerve burning, tingling, same thing. But there's an emotional event part of it. So we can still apply some things, but there are limitations. But neuroplastic pain is learned, it's predictive, and it's reversible. It is basically neuroplastic pain is the fear-based adaptation of the nervous system. And that's what that pain cycle is that we've got up here is talking about. It's a self-reinforcing loop. And you can enter on the left side, I should have added this, I apologize, but add injury on the left side in between those two.
Okay.
So if you enter with an injury or surgery, but you're going to have an emotional experience with this surgery, it's going to be painful. There's going to be some suffering. You're going to feel some emotions about this. Even if you haven't had any trauma in the background, you're still going to have an emotional event, because the International Association of Study of Pain says that pain is a sensory physical event and it's an emotional event. So you can enter with an injury, or you can enter with how I entered at 7 years old with emotional stress, mental stress, things like that. Then you have this emotional stress, and then you start avoiding behaviors. You start either resting too much, fear of movement.
Mm-hmm.
This fear wires in. It starts making meaning to this pain. If I get up and go for a walk to my mailbox, it's going to cause pain. So then we don't do anything. Then we lose our lives. We have grief from what we've lost. That starts playing into the pain cycle. All of this lends itself to a centralized, a heightened nervous system, the sensitivity. So this is the loop. So you may have had an injury, but all of this looping, if we're not very, very careful, it becomes the pain experience, all of those things in that loop. Does that make sense?
Mm-hmm. Absolutely.
It absolutely does. And I think the one interesting piece that is internalized, as you kind of mentioned there, and maybe difficult for both providers, clinicians, and for family members to understand, is if you got a welt or a cut or a cast or something along those lines, it's an outward facing element that shows that there's likely some kind of pain underneath of this, then it's easy to be able to attribute this individual is in pain, and therefore I can understand to a certain degree that they're going through pain. But when there is no cast, there is no bump, there is no swelling area, now there's a disconnect, between individuals of understanding those pieces. When you're describing this pain cycle, I'm positive, because I've worked with enough patients that have described this exact same cycle to me, that it got worse, Kevin. Like, what ended up happening is I got the treatment, I came off the treatment, that fear and anxiety welled up, I did less, I started to feel more pain, I started to produce more heightened nervous system related pain and frustration for myself. And then the cycle continued. But when you're describing it to a family member or another care provider or something along those lines, have you used anything other than this kind of pain cycle illustration to be able to push the point home, Cynthia, on what is this individual going through that's in your life?
Yes, probably more break it down from the emotional stress and the unresolved experiences. I think it comes down to hearing. I think we talked about that before we started, is talking about being heard and being believed. So that's what the support that's where the support comes from. So when I explain the pain cycle, I explain it basically the same way I just explained it, so that they can see this heightened sensitivity of their central nervous system and see that it's not just someone whose complaints are just getting louder and louder and louder. It's literally their nervous system is getting louder and louder and louder, because the source of the pain is not being dealt with. and the pain is going to, you can go have a surgery, and maybe that pain goes away, but it's going to come out somewhere else. It will keep coming out until you deal with the source. And we're talking about neuroplastic pain.
And
the mental stressors.
We talk about this often. Thank you for that, Cynthia. We talk about it often, Donna, in anxiety, right? Like this exact same kind of loop that we see end up happening. And I'll share a quick story. It's tough as a dad. My little boy was stung 15 times by a group of hornets that popped up. And so now he has that emotional stressor. And anytime there's a bee or something else around him, like an instant scream and run, kind of feeling that is very reactionary, that ends up happening. And that's in his little brain. That experience comes back immediately, right? We had some kind of PTSD related components, some anxiety related to it. And we can see and understand that process. We've seen it as clinicians quite often. I don't feel like it is that far away from the nervous system and or thought processes that we're dealing with here with neuroplastic pain. A similar loop, other than the one piece of that heightened nervous system sensitivity that you're mentioning there, Cynthia. When it comes to that, like that heightened nervous system sensitivity, would initially for you, would pain medications or any other treatments initially were starting to bring those levels down, probably due to sedation of anything else, and then the doses just weren't enough? You just couldn't get more relief? Or did you notice that some things did help that were related to an antidepressant or something else that was a cognitive kind of component for therapy?
The pain medication, I worked in pharmacy as a pharmacy technician a very long time ago. So I knew there was a ceiling on pain meds.
Yeah.
I mean, I just knew it. So I went to my doctor and I said, let's move these back down from Percocet. I want to move them back down to Tramadol. And I think I've kind of lost what your question was. I apologize.
No, I was just wondering if when you were looking at this loop, I'm looking at my other screen. I should bring it up so we can all peek at it together. How about that, Kevin?
Okay.
I'll bring it back up. And I was really looking at that emotional kind of stressor component, right?
Okay.
And thinking, okay, great. We have all these different treatments for pain, right? And we know that when you're looking at heightened nervous system sensitivity, like it's just getting worse. Unfortunately, the pain level and the thresholds are getting worse, that I'm not able to treat something with a typical treatment. Everybody else thinks, well, that's a big dose of an opiate, or that's a lot of Tylenol or ibuprofen, but it's not doing anything for you. My question was it working or doing something initially, and then basically because of that heightened nervous system sensitivity then went away? And did you ever utilize a pain therapy that was unrelated to our typical nociceptive or neuropathic pain elements, and that started to happen?
Yeah, for me, the pain meds, I'm like, I've heard this over and over again. I never really knew that they were really working, but there was that fear of stopping taking them, of what the pain may be, and then the coming back from the pain. So in the beginning, it was the pain meds. It was the gabapentin. I was on crazy meds. I was on Ativan 1 milligram 3 times a day, along with the Percocet, along with the gabapentin, along with antidepressants. And I'm open about this. I've worked with Donna on changing some of these medications because I no longer need them. But nobody talks about this when they're prescribing.
Yep.
How do you get off these medicines? How do you stop taking them? But there wasn't anything else at that time, to answer your question. There wasn't anything else at that time. I still was unable to figure out what to do until I went back to school, and I was in the pain coaching school, and I was reading all these books. And then it started. At first, I was like a little bit hesitant to believe it, because I was like all the other pain patients. I don't believe you anymore. You guys are lying to me. You're treating me badly. And so, but in the beginning, I was very hesitant. I don't know if I buy this. This is all mental. This is all emotional.
Yeah.
And so it took me time. It took me a lot of reading. It took me talking to a lot of the researchers and speaking to them and trying to really understand that this is real. This is very real. We have pain that it can be produced from trauma, from anxiety. And you talked about anxiety a minute ago. I believe that there's kind of a trajectory.
Yeah.
There's a trajectory to pain. And when you feel pain, you've missed all these signals prior to the pain. The pain is the last resort of the brain. It's going to get your attention, and that's why we have pain. It's a teaching signal. It's a harm alarm. It's a danger. It could be a paper tiger, could be a real tiger.
Yeah.
So when we're dealing with mental and emotional, those are the paper tigers. And that's what I help people try to start seeing, finding the gap in between the stimulus and the response, rather than having the knee-jerk reaction that, oh, I got to take the pain pill, or, oh, I've got to do this, oh, I've got to go lay down. Find the gap. What's something else that I can do in the gap that I can get back to safety? So that's the other thing. We've got to change the goal. It's not to get out of pain. And people look at me like I'm crazy when I say that. The goal is no longer to get out of pain. The goal is to get your nervous system back to safety and out of feeling like you're in danger, because your brain is misfiring. So getting back to safety, getting the nervous system embodying the safety is really key. It's not just thinking positive. That's not what I'm talking about. This is embodying. This is really living safety again, how you were supposed to live. And I say, before the world got its hands on you. You're born whole, but then the world gets its hands on you. And so then now we've got to come back from all of the trauma, the emotional, and the mental stress, if that makes sense.
Yeah, I mean, it does. And I think you went to a really beautiful, deep level on that. I think the one piece that I'd be remiss not to ask in the episode is, you went through everything that the world was throwing at you, including the Western medicine world of, okay, here's the PT, here's these next steps, here's some yoga, here's some pharmaceuticals. Nothing was working. It was making it likely worse, making you more miserable, disconnecting you from family relationships, so on and so forth. You got to this epiphany point of looking at research and being able to get things start going in the right direction. Give us some of the first, here's what I did, right? And here's some of the exercises I did that finally made me go, I have a way not to focus on just getting rid of the pain, but living my life again.
I think a really good example would be going for a hike. And when I say hike, I'm not talking hike, because I'm still building stamina and all that stuff. Right. But it would be going for a walk, because I remember in the very beginning being very afraid of going on a walk with my partner, and just feeling fear, embodying fear that this is going to increase my pain, then I'm going to be in the bed, and then I'm going to be down for 2 or 3 days. Just a very simple, flat, short hike is causing all this. So what I started doing is talking to myself, my brain, and saying that there's no reason to produce pain in this moment. There's no reason. Walking does not cause injury. Just walking a very slow pace. So it was a lot of self-talk. It was a lot of changing a belief system. That's why believe is everywhere. It's all over my house. The word believe. We're changing a belief system. To back to self-worth, back to self-trust, those kind of things. I'm sorry?
Did your brain believe you when you said there's no reason to create pain right now on this
in
walk?
The beginning? No, because that's the key of it all, is consistency is the key. And I'm not talking about perfection of every single day. We're talking about consistency enough to make a cumulative effect in your nervous system. So you start embodying these feelings, if that helps. Absolutely.
So how did you stay with it? I've got to ask that piece of just, it didn't work at first. Like, if everybody's quick fix, in society. And so being able to train yourself to go, this is going to take time, and I'm going to be consistent with my messaging. How did you, have the resolve to be able to do that for our audience, to be able to hear, here's the trick, right? There is no trick. I'm sure you're going to tell me it's just a lot of work, right? But how did you keep with it? And what was the messaging you continued to tell yourself when you kept going on that walk, even though you're producing a high level of pain each time?
For me, it's believe. That's my word. It's for my whole life, I did not feel believed. I didn't feel believed, and I needed that, and I needed to learn to believe and self and trust myself. And so there were times where I was like, this isn't working, and you stop and you're not doing it anymore. So there was a pickup. So it wasn't just this beautiful, oh, this is working and it was all great and happy ending. It was a zigzag. It was a back and forth. It was a falling in holes.
Wow.
But it's about getting back up. And that's what I tell my people. There's, I think it's a Japanese phrase, fall 7, rise 8. The numbers are not important. It's that if you fall, but get back up, keep getting back up, because that may be the next time. That may be the time that you stay up. And I think I just kept saying I had to believe in myself. I did at that time. I was just really struggling. So I just kept putting one foot in front of the other and saying, I'm going to change this. I am going to get my body back. I'm going to get my mind back. And then I decided I could not just go about my life with all this information and all this knowledge. I have to go back in, and I have to pull these people out of the burning fires, how I feel about it.
Wow.
Cynthia, can you explain some things that I've read on your website and through exploring a little bit more about this? What is the pain neuroscience education, or the pain reprocessing therapy, or that emotional awareness expressive therapy? Could you teach us a little bit about that? And it sounds like you might have already done that a little bit, but are these like specific things that pain coaches would do with patients, or who works with patients on these?
Well, most of this is the way I have put together my coaching program is I use evidence-aligned coaching modalities and approaches. And obviously the coaching is the basis, but then you get into the pain neuroscience. That's the foundation. But we do know that education is not enough. So we start with the pain neuroscience. That's just basically education about how the pain is processed and how the brain and the nervous system work together, and they're producing pain. We learned that pain is protection. We learned that the brain, it doesn't matter what kind of pain you're dealing with, the brain is it's making a decision to produce pain 100% of the time. We learn we learn about how emotions and thoughts influence the pain. And then we learn about how we start learning some ways to change the pain experience, but it's a very slow. So first we do the pain neuroscience education. Then the way I work with my clients is once they get this information, either it makes sense to their story or it doesn't. So they decide what they're going to do next. I don't tell them, okay, now you're going to do X, Y, and Z. They decide, I want to do part 2 of your program, which is the interventions. And that's where the pain reprocessing principles come in. And that's just basically is teaching people to understand that it's a misfire. It's understanding that it's a harm alarm, it's misfiring, and then we start experimenting with safer, calmer responses. And that's what I was talking about a minute ago, between the gap in between the stimulus and the response. We have to find that gap. We have to slow it down. And that's where some of the pain reprocessing principles come in there. The emotional awareness and expression therapy. I've said in the course, I am not certified because I believe that is a therapy that mental health professionals should be doing, because that coaching can only go so far. If you've got a lot of stuff under here, like trauma, things like that has not been dealt with, they need a therapist. Not just a coach, they need a therapist, either work in conjunction or work separately. So the EAET, that's more along the lines, like I said, for the therapist, and they take the client into the very, very strong emotions that are still stuck in the body that they need to get up and out. And I can do basic stuff with expressive writing, but when you're talking about trauma, unprocessed stress, anything like that, that needs a therapist. So that's part of my program is I'm evaluating, and I've been trained to observe if they need more help than what I can do as a coach. So that's what those three are.
Interesting.
Did I answer that?
No, it totally does. So, okay. So what is the training for a pain coach, and what would somebody look for, say like, okay, I'm really struggling here. This speaks to me. How would a patient start looking into, okay, I want a pain coach? What do they look for, and how do they maybe interview someone or feel that this is the right move, the right direction for them to move in?
I'm very biased on National Board Certified Health and Wellness Coaching. There's a very specific reason why I chose that, because my background is business, my background is accounting. And I decided through all of the changes that I made, I figured out that I coached myself by saying, okay, that didn't go well. Now what do we do next? Instead of sitting down in the learned helplessness. So I would want to find somebody with a National Board Certified Health and Wellness Coach, specifically for the reasons that I have it in my program, is because I help my clients determine what's really important to them. I support them in making the changes, which is doable, meaningful, and lasting. And this honors their nervous system. So I'm not telling them what to do. I'm pulling it out of them. So I believe coaching is a dance. So it's not me being directive. I'm helping them figure out what they need to do, what changes they need to make. And then that's how it's lasting. So what they need to look for, of course, like I said, I'm biased. I would look for a National Board Certified Health and Wellness Coach. We help people find their own wisdom. It's a dance. Coaching is a dance, and it's a conversation, but it's not me telling them what to do. So that's why I think it's really good for people with chronic pain, is because they've lost their ability to self-trust, to make decisions and go, okay, this is a good decision and I'm going to go do it. They've lost this ability. For the interviewing, obviously ask about what their training is. I think you need a well-rounded base of modalities and approaches. I do not think that one approach is the only way. So I think you've got to piece together the P&E and the PRT and all that. So I would ask them about, have you trained for the pain reprocessing therapy with the Pain Psychology Center? Have you at least explored the EAET, so you understand when you're out of your lane and when as a coaching lane, and when, those kind of things. The other thing I would ask them is just ask them, about neuroplastic pain. How does their treatment plan? Is it just talking? Do they have lessons? Do they have exercise? Do they have experiments? How does their program work? Right now, there is no this is how you become a pain coach. This very all over the place, to be real honest. People are becoming pain coaches just by taking the PRT course. People are becoming pain coaches just by taking a life coaching course. So people are coming at it from all different avenues, and that's why I'm I think the NBC, we are the only, we're recognized in the healthcare industry. We're credentialed members of the healthcare industry, so we are in the medical field. And we also understand and we learn about the lab works, and so that's also a factor into, you need to understand the health of the person you're working with, not just the pain. You've got to understand the whole big picture. So you interview and you just ask, how do you do this? How do you change? What do you do in your program? Those are the things I would ask. And especially the trainings.
Yeah. If you guys will indulge me, I've got to have us nerd out together for just a second. So I'll add this here. So one thing that's really interesting is at the very beginning of the episode, and this is It's from a great Nature article that I read before we had our get together here in our episode on modulating neuroplasticity of chronic pain. And it goes through, these are all nerve endings and showing here's the different neurotransmitters that are being exchanged. So for those clinicians that are wondering, like, what in the world is going on here? How do I understand this to a deeper level? Great article to be able to break those things down. And also, when it comes to the belief that I know that Cynthia wants us to have as clinicians helping patients, one thing we have to believe is in further training ourselves to understand what neuroplasticity is, how our bodies can modulate pain reception and inhibition of pain. And sometimes we downregulate inhibition, as this shows. There's a maladaptation that ends up happening here. We don't actually inhibit pain signals. So as Cynthia was illustrating in her cycle here, that heightened nervous system sensitivity is exactly from this component here, where we're not continuing to inhibit those pain signals in general. So thank you for allowing me to nerd out a little bit for those clinicians that are really wondering. I don't understand the components related to how this is happening in a human being's body and how we're trying to treat it. And so related to that is the other piece they talk about in that article is neuromodulation. Cynthia, I'm really curious, when it comes to the coaching, the counseling, the tracking, me being a like data and tech nerd, the two things that I have to ask you is, one, is there anything when it comes to tracking applications or mobile applications or something else that you've advised individuals to use to help them along that journey when they're trying to coach themselves along the way and see the progression? And then the second piece is when it comes to any of these neuromodulation elements that are in play. So a lot of them are related to like magnetic stimulation or current stimulation, that we're doing something, we're going in and we're having a clinician be able to stimulate individual sections of our brain and doing that therapeutically. So both sides of it. One, the tracking without this neurostimulation, what have you seen and what have you advised your clients to be able to utilize? And then two, any thoughts on the neurostimulation stuff?
I guess I'm biased on all of this too. I work specifically with the mental and the emotional and the talking pieces of it.
Yeah.
I think all of these things just fall in place from lending when we start restoring to self.
Yeah.
All of this starts coming into play. If you're asking me about different apps that maybe they may use, I really don't use apps or anything like that. It's just my program, the lessons, and we go through each lesson. But the progress is very, very minute on when we're doing this kind of work. So I do, what I do is every so often I'll do a progress report so they can see they're like, wow, I didn't know that, 3 months ago or 4 weeks ago, I wasn't doing X, Y, and Z. And now I'm doing it without even thinking about it. Mm-hmm. So everything is falling, all of that is falling into place, but I'm doing it in a totally different way. Mm-hmm. Does that make sense?
It does. Yep. Yeah. And then the neuromodulation components, have you had any patients with any experience there?
No, I have not.
Okay. That's super helpful. Thank you.
So just a general question, because I'm trying to also put this in context for what the general public might be thinking about in regards to, how do they think about this neuroplastic pain? And one thing that hit me is chronic fatigue syndrome. Is that kind of like this neuroplastic type of pain where you kind of go from doctor to doctor and no one really quite knows what exactly is going on, and you're treating it from different angles, where you might have an antidepressant or anti-anxiety, you might have some pain type of relief to maybe you're using something that is like venlafaxine or duloxetine, for example, that might be both emotional and pain types of indications for using that medication. So am I right in thinking this? Because I think that that's a term that a lot of people could probably hang their hat on and understand and have a general concept of, versus what is this neuroplastic pain that they're trying to talk about?
Well, yeah, chronic fatigue, like I said, you've got pain, but there's a lot of symptoms before you hit that pain. And fatigue is one of those. Or maybe that's just what your brain, that's the path of least resistance. Maybe that's just the fatigue is your thing rather than the pain. Yeah, so they're working with medications. I generally don't get into medications because it's so far out of scope. But I do hear as clients progress through the program, they're learning why their brain is producing the fatigue. There is some fear there. What is the fear? So they're working through this stuff. The medications may need to be on board until they get through working all of the emotional and the mental stressors. And then they can slowly, working with their doctor, not with me, working with their doctor, they can slowly make the determination if they want to stop the medication, and then they do the tapering with their doctor or whoever, or the pharmacist like you guys. So that's how it kind of played. But yes, I feel like that can be very much everything. I can't say yes, you have neuroplastic pain, but that chronic fatigue, it makes total sense. And it's what I've seen in clients that have the fatigue along with the pain. It's like their body is just going, you're not going to move. It's dangerous. You're not going to move. So we have to undo that fear.
Got it.
So that then you go, I can move. It is okay. I can take 3 or 4 steps, and the fatigue is not going to, it's not going to take me out. So it's a lot of changing erroneous belief systems. It's a lot of full belief system. That's why believe is everywhere in my house.
And I think to piggyback off of that one, that believe and the hope that you talked about initially, and I love how you were very cautious with using the word hope, just because it can seem like such a dark place that just painting a word that is a beautiful term, but ends up getting utilized so often that it can almost seem flat for those individuals that feel hopeless for so long. But trying to provide one thing that I'd love, Cynthia, is if you could give us your favorite story of a client that went from feeling hopeless to getting it, and just kind of leave our audience with that piece.
I worked with a client that came from a very, 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 very troubled family. And I knew immediately that he needed help. So I worked him, and he got him into the right therapist, and he continued working with me. And we worked together, and I think it was about a year that we worked together. But by that year, he had reestablished his life in a way that he was happy. He wasn't isolated. He was going and doing things. So slowly he made these changes. But in the beginning, he was angry, road rage, just all these really strong emotions that were so stuck, and he never got to voice it. And so through my program, he learned a lot about himself. He learned how to restore balance with himself. He learned how to basic regulation, thoughts, emotions, which lead to behavior. So we worked in there. Then he worked on the social stuff. But with the therapist, he worked in the EAET. Okay. This combination of all those modalities that we talked about earlier, they work really, really well together in combination. So now he just did, I think it was about 3 months ago, he did the post-program survey, and it's a different person. The things that he's saying and the way he's living as a different person. He's happy. He's not suffering, and he's not in pain. And throughout our journey, he even had shoulder surgery. And he did not develop chronic pain in his shoulder through all of the education and the information and all the work, the hard work. And that's the thing I want to tell people. There is hope here. There is real hope here, but it is not a quick fix, and it is not overnight, and it is not one modality. It is a combination that I call a container of safety. Until you figure out your container of safety, you're going to be in pain. Until you use more than 4 interventions for your pain, you're going to be in pain. You've got to get a container of safety. And that's what my program does in the second part, is I help them build that. And then we rebuild their life with visioning, if that makes sense.
Mm-hmm. Wow. No, thank you so much for your time and for that. I think the not being ourselves is something interestingly being robbed from so many because of pain. And to be able to give someone some hope, to be able to be themselves again, to enjoy life again is a beautiful calling. And I'm so thankful that you've gotten to the point you have with your own pain and are able to go back and help so many others, Cynthia. So thank you so much for joining us today. Donna, any other closing remarks for us?
No, thank you so much, Cynthia. And I think the other thing that I know that we talked about earlier, but I just want to reiterate, is the clinician side, to really listen to those patients and know that there's pain coaches and, wellness coaches, right, that are a part of the medical team. So I think that in itself is great information. So to lean on those, on people like you in order to help our patients in an interprofessional manner.
Absolutely. I think listening is key. There's always, that's the one thing no one ever asked me in 50 years, what happened to you? Never asked me that. I fell through every hole, every crack. And so that's what clinicians need to really, they need to look and hear what is really in front of you. This person has value. They are a human. And I'm not trying to beat up the medical community, because I know they want to help. They're trying, and they've got hands tied for different reasons. So this is very, very, very complex on trying to figure out the whole thing and change the healthcare system. But first things first, believe the client. They have the best information about themselves. They know themselves, and they can help with their plan, with their treatment plan. So that would be my advice.
Well, I love it, Cynthia. Well, thank you again so much for joining us. And audience, thank you guys all for being here. So excited for this 4th season to be kicked off with Cynthia and some wonderful words of encouragement there. Look forward to seeing you guys next time. Like, share, follow. We're on YouTube, Facebook, LinkedIn, and all your streaming apps that you could ever want to see. We'll talk to you guys next time. Have a great rest of the night.
Take care.